We have a superb speaker up next. It's Dr. Neha Shah. She's going to talk about latent TB, risk factors, the new treatments, and new tools. Dr. Shah is a field medical officer with the Centers for Disease Control and Prevention. She's assigned to the California Department of Public Health. Prior to coming to California, she was a TB controller in Chicago and did her Epidemic Intelligence Service training with the Division of Global HIV and TB with the CDC. She's part of the MDR, or Multi-Drug Resistant TB Consult Service at the California State TB Control Branch. So please join me in welcoming her.
Hello, everyone. It's my pleasure to be here. This is very exciting to see so many people. I'm going to be talking about latent tuberculosis, and feel free to stop me along the way if you would like, although keep in mind you will be delaying your lunch, but I'm okay with that. Just the required disclosures. I don't have any disclosures. I will be talking about the use of rifampin for latent TB infection, which is off-label. Objectives, we'll just keep going. Okay, why should we test for TB? Well, I think we know all of this. We have a lot of tuberculosis in California. This is how many cases we've had since 1991. We have been having a steady decrease up until last year, where we had an increase of cases. We're not sure exactly if this means that we will be seeing more cases or we've just kind of hit a stagnation in the decreases of TB cases. In California in 2015, 80% of our TB cases are among the foreign-born individuals. And yes, that is 2,000 little people. It took a long time to make. But it was a nice Friday, quiet Friday. Of those 2,000 cases of TB, 10% of those cases die, which really is one of the consequences of active TB in this country. 10% of people will die from TB every year. There is a lot of morbidity after treatment. There are patients who have a shorter life expectancy. The cost of treating active TB is enormous and continues to rise as medications for TB become more and more expensive. And public health treatment of latent TB is really where we need to be going in the future to decrease the chances of having TB cases in the U.S. Where do all these TB cases come from? How do they happen in the U.S.? Well, about 7% of them are from importation, so people who come into the U.S. with TB are diagnosed soon after coming into the U.S. About 13% are due to transmission within the U.S., so somebody with TB transmits it to somebody else. And then the vast majority of the cases come from reactivation. So people who have had latent TB, who then later in life, either they've become immunocompromised or they've developed diabetes, they get dialysis, their TB reactivates and becomes active TB. When do these TB cases occur? I think you saw a slide similar to this earlier in the day. The majority of them happen about 1 year after arriving in the U.S. However, it's really important to note that 75% happen when people have been in the U.S. over 6 years, and when you look closer, 50% or more people who've been in the U.S. for over 16 years. A lot of times we focus on the recent immigrants, but really people have been here for a very long time and are then going on to develop active TB disease. Looking at active TB disease is really only one part of the picture. As I mentioned, we have 2,000 cases of TB a year, but the bigger issue are these 2.4 million people who have latent TB infection who can go on to active TB disease. And that's really what we need to focus on if we're going to continue to make a dent in decreasing our TB cases in the U.S. Looking at those 2.4 million people who have latent TB infection in the U.S., how does that break out? Well, about 1.85 million of those are among the foreign-born population. The vast majority of those individuals with latent TB are in the foreign-born population. Nutritionally, most of them do not know that they have TB infection. These are data from a U.S.-based survey, the National Nutrition, Health, and Examination Survey, NHANES, that was done in 2011. And what they found was that of the 2 million people who had latent TB infection, only about 20% of them were aware they actually were infected, and 12% were treated for latent TB infection. So there is a very large gap here in those who are infected with TB and then those who are aware of it, and then again, even less who are treated for TB. Just to summarize, most cases in the TB are due to reactivation and are therefore preventable. TB has a lot of morbidity and mortality, and there have been some historical barriers that have impeded the adoption in many practice settings. How to test. Okay, this is where we have some audience participation. If this is the case, a 34-year-old female who was born in India, she came to the U.S. at age 15 on a student visa, has no other health problems, starting a new job, and therefore is changing visa status to employment, to an employment visa. She sees a civil surgeon for the first time. What do you do? TST, IGRA, both, nothing? Call somebody else. Help. B, we have some Bs. We have some A's. A's, okay. So nobody wants to do C, D, or E? Okay, that's fine. I won't be offended you don't call me. We'll go on. We'll figure out what the answer is. But TST, Mary talked about this a little bit, so I'm not going to spend too much time on it, but we still use the TST, and I will say it is a great test, especially among certain populations. As she mentioned, and I will reiterate this as well, you measure the induration, so the elevation, not the redness that is around the TST. And I will agree with Mary. When I was in Chicago, I had to teach my staff how to do the TST again, because you really need to have a little bump when you put it on there, and not everybody does it correctly. So I would encourage you to refresh yourself if you feel like you don't know how to do them, but you want to measure the bump, not the redness. Interpreting the TST, now I know there was a lot of discussion about how to interpret the TST. How is it different from your technical guidance versus what we do? It's actually the same, it's just the entry point's a little bit different. That can get a little bit confusing, but it's really generally the same. People who have a TST of 5 millimeters or more should be considered positive in the left-hand column, and I highlighted in red here where that kind of confusion comes up with the chest x-ray. So anyone who has a chest x-ray with fibrotic changes, a TST of 5 is considered positive. It's the same thing Mary said, except it's a little bit in the opposite, in the reverse order, chest x-ray and then TST. But it's the same thing, 5 millimeters for people who have changes on chest x-ray. And then everybody else, if it's 10 millimeters or more and they are getting a TST for whatever reason, that must mean that they need one or there's some sort of risk factor. 10 millimeters or above is really what we consider positive. And again, I've highlighted at the top kind of the group that you're most likely to see recent arrivals from high prevalence areas or just a foreign-born individual from high prevalence areas. IGRAs, again, Mary talked about this a little bit. There are two IGRAs, and they both have representatives outside, the quantiferon and the T-spot. They are reported, the results are reported a little bit differently, and I'm going to go into how the quantiferon results are reported. That seems to be the most popular test that's been used around California. What's the difference between the TST and the quantiferon? Specifically, what we are very interested in is the specificity. So we want a false test. We want a false test to be really false. The quantiferon has a much higher specificity than the TST in individuals who've had BCG vaccination, which is really the majority of people that you are most likely to see in the foreign-born, and significantly better, 59% versus 96%. And so why is that important? Well, you really want to test with high specificity so you can reduce the likelihood of getting a false positive result. And I put this up here so you can kind of get a sense of how many false positives you would have if you used an IGRA versus a TST. And with the TST in a BCG vaccinated population with a low specificity, you're going to get a very high false positive rate, which is why we really suggest using the QFT in foreign-born individuals if you can. Other advantages of the IGRA versus the TST, as I mentioned, it's not affected by the BCG vaccination. It's not affected by other mycobacteria. There are some 200 plus other mycobacteria, which does make a difference in some parts of California, so that's very helpful. The interpretation is objective. You don't have to feel things and try to mark it. It's positive or it's negative, and the lab tells you that, so you don't have to think about it. There's no return visit needed. And patients and providers often will have a lack of confidence in the TST. I have lots of patients who say, oh, my TST is positive because of my BCG vaccination. I'm sure many of you have heard that, even though they have a raging BCG, a raging positive result with like 30 millimeters. I have a hard time convincing my patients that's positive. So I like the IGRA in that sense. How do you interpret the results of an IGRA? This seems a little easy, except when we get to this bottom indeterminate category. If a positive test, simple, TB is likely. Negative test, TB is unlikely unless somebody is coughing and coughing up blood in your office. I would still not necessarily believe the negative IGRA. And if you have an indeterminate, there are a few things you can do. You can either repeat it, you can try a TST, you can look at the actual result of the quantiferon, and I'll go into that. Or, as Mary mentioned, if somebody really has signs or symptoms of TB, just move on to the x-ray and look for a different way of getting your diagnosis. Reading the quantiferon results. So recently, a few years back, labs were required to actually report out the numerical value of your quantiferon test. And a lot of people may not have seen this or know what to do with it, but it is very helpful, especially in indeterminate cases, or if you have a patient who you don't think should have a positive test, it's helpful to look at these results. So this is what you'll find. You'll find the nil, which is your negative control. You'll find your mitigen minus the nil, which is just what your quantiferon, your positive minus your nil, and then the TB antigen minus nil, which is this last one is really what you want to look at. That's how you determine positive or negative. If that TB antigen minus nil is greater than 0.35, that's your cutoff. It's going to be reported as positive. If it's less than that, it's going to be reported as negative. In this particular situation, a 7.03 is very positive, much higher than 0.35. Now, this is helpful because you will get individuals who you don't think should have a positive result. And if you look at this number and they're at 0.37 or 0.4, you may think, well, that's really close to the cutoff. Maybe I'll retest. Maybe this person really has no reason to have a positive test. You can really use your clinical judgment at that point to try to understand the test a little bit better. And similar with the indeterminates, you can kind of get a sense where in this category are people falling. Does it really look like they're going to be positive and this is just an issue with the test that I drew? Should I redraw it? Or are they closer to the negative value and they probably aren't going to have TB. I will tell you there are a lot of ways for quantiferon to go wrong, and that's why it's helpful to look at these tests. And it's also helpful if you get an determinant to repeat it because there could be a number of things that could have gone wrong. The CDC guidelines that are put out by the Division of TB Elimination suggest that IGRAs are preferred for people who have poor rates of return, so often homeless individuals or people in drug rehabs won't come back frequently, or people who have received the BCG vaccination, so foreign-born individuals. The TST is preferred for people who are under 5 years of age and usually U.S.-born individuals who aren't BCG vaccinated. Although I will say the caveat to that part is Mexican individuals or children who are of Mexican heritage who are born in the U.S. but then go back to Mexico, I would really try to ask if they've had a BCG because often they will have. If you don't know whether somebody has had a BCG or not, because not everybody gets it, there is this wonderful tool online called the BCG World Atlas, and unfortunately, I don't think the hyperlink will work, but that's all right. What you do is you plug in the country at the drop-down, and it tells you whether somebody has been BCG vaccinated or whether what the practice is in that country. What I did is I plugged in our female from our case who was born in India, 35-year-old born in India, and it spits out whether this person is likely to have been BCG vaccinated. In several countries, people will be vaccinated multiple times, and it will tell you whether there is a likelihood of them having been vaccinated several times. And that'll help you decide whether you want to do an IGRA or TST. Just to remember, and Mary mentioned this as well, if somebody has signs or symptoms of TB, an IGRA or TST cannot rule that out. It is one diagnostic tool. Make sure you continue to use your clinical judgment, and if you do have a negative, but you really think somebody has TB, continue your evaluation. Just in summary, your IGRA or your TST can aid in your diagnosis. Neither can distinguish between TB infection, latent TB infection, and active TB disease. And IGRAs are usually preferred in certain situations versus others. How to treat? Okay, another case. 60-year-old woman born in Vietnam. Her daughter was born in the U.S. And has recently had a baby, so she wants to move to the U.S. to spend time with her family. The IGRA is positive and the chest x-ray was normal. She's never been treated for TB in the past. So what are you going to do? You're going to treat with INH, treat with rifampin, don't treat because she's 60, send her somewhere else, or get some sputum. This doesn't have as vociferous of a response. Three. C. Okay. I hear some murmurings for do not treat because she's 60. Young, 60, I should say. 3. Yep. 3. Okay. Nobody seems to want to vote for anything else. Okay, so we're going to go with don't treat because she's 60. Okay. Let's review this. There are 3 regimens for latent TB infection that you can choose from. Rifampin daily for 4 months. Rifapentine and INH given weekly with directly observed therapy right now for 3 months. Comes out to 12 doses. The only one of these in single numbers, or 2 numbers. INH daily for 6 or 9 months. I think everyone's familiar with that one. What I would say is whatever you choose, do not give your patient a prescription for the entire treatment course. Try to see them at least once a month. At least in the beginning, if you're going to do INH, at least try to see them for a few months, but do not give them a 9-month prescription or a 6-month prescription or even a 4-month prescription. Try to see them at least after the first month. Make sure nothing is going wrong. I will tell you I have seen several patients who have a 9-month prescription and have developed hepatitis at some point in their treatment and just didn't stop taking the medication. So please do not do that. Rifampin. Rifampin is given daily for 4 months. It has very good adherence, 78% versus 60%, very low hepatotoxicity. The issue with this, which is why it hasn't been really been adopted very quickly, is that there isn't a lot of efficacy data related to rifampin. Fortunately, there is a large randomized control trial going on right now that will give us the answer to that. Hopefully next year those results will be published. But there are data from what is called a network meta-analysis, which is kind of complicated, but it really suggests that for the 4 months of rifampin is as efficacious as placebo. So this is a very good regimen, high completion rates, low hepatotoxicity, only 4 months. People can take it on their own, and it is becoming more popular. INH and rifapentine, this regimen came out in 2011. I would say probably in the last year there has been an increased use of this regimen, and I'm going to go through it with you right now. This regimen was introduced, as I mentioned, in 2011 by way of the New England Journal. It was a randomized controlled trial. Both arms had about the same number of individuals. INH rifapentine is given weekly for 3 months, and it's given by directly observed therapy. And that was compared to INH given for 9 months, self-administered, and was given daily. The results were that they were both equally effective. This was not made as this was not set up to prove one is better than the other. It was just set up to prove that they were equal. So they are equal, though you can see that the likelihood of TB with the INH rifapentine or 3-HP course is less than the INH. There was a much higher completion rate in the shorter course, and there was a much lower rate of hepatotoxicity. So overall, a much better regimen than the INH regimen, except for this caveat of having to give it by directly observed therapy, which I understand is a big caveat. There have been some follow-up studies of this regimen in children. It had the follow-up study for children had the same results as that for adults, so it can be used for kids all the way down to the age of 2. And in HIV-infected individuals, again, perfectly fine to use as long as they're not on antiretroviral drugs. This study has not been published yet, but has been presented, I believe last year, and hopefully the paper will come out soon, looking at giving the 3-HP course by self-administered therapy instead of directly observed therapy, because it's very hard for a primary care provider to give directly observed therapy. In fact, probably near impossible. So they looked at whether you could give by self-administered therapy and what were the completion rates. And in the U.S., there were several international sites, but in the U.S., they had the same completion rates as with INH, as with directly observed therapy. So this would suggest that we can give this regimen by self-administered therapy instead of using directly observed therapy, but the paper has not come out yet, and CDC has not issued guidelines on it, but it seems as if this is a potential option. Okay, INH, people are probably familiar with this regimen. It is 60 to 90% effective depending on whether somebody actually takes it or not. The completion rates are pretty low. It's a long regimen, and there are a lot of side effects. So hepatotoxicity is pretty high, and it increases with age. What about age? So the most common response was that we wouldn't have treated this individual that we talked about because of her age. Younger persons have a longer life expectancy to progress to TB. However, 20 to 30% of our TB cases in California are among people who are age 60 or above. So if we want to do prevention, we're going to really have to target that group. The LTBI prevalence increases with age, and yes, older age is a risk factor for death in people who have TB disease. So this age issue is really a problem. In the past, there was a cutoff of age. I believe it was 35, which seems completely ridiculous to me because I'm way over 35 now. But that criteria was removed quite some time ago. So there is actually no age limit for treating LTBI. But I would encourage you to just consider the comorbidities. So if somebody has hepatitis, you probably don't want to give INH. You might want to give rifampin. But there is no age limit, and I would say that I would encourage people who are healthy, especially healthy 60-year-olds, 70-year-olds, to be treated for latent TB infection. You might want to keep a closer eye on them, but they do contribute a considerable amount of cases. So don't use age as a absolute cutoff. So our key points are short course regimens have higher completion rates and are less hepatotoxic. The short course INH rifapentine is as effective as the 9 months of INH. And INH can still be used, but I would say it is not our preferred method of treatment for latent TB infection anymore. So our last part is TB elimination, or what I would call your crucial role. Just as orientation, what are we calling TB elimination? Well, elimination is 1 case per million, which is 39 cases in California. We're at 2,000 now, so we've got a little ways to go. Pre-elimination is 388 cases in California. It's a little bit more feasible. Our dream is to get to elimination by 2040. Well, let's see if that's possible. Right now, if we continue at the percent of decline that we are at, we will not get to elimination or even pre-elimination by 2040. If we increase our rate of decline to 4% instead of closer to 2%, we can get there. We can get to elimination around 2114. So we have to do a lot to get to a 14% decline rate to get to elimination by 2040, which seems impossible, but we've done it before. In the 80s, we had a much higher rate of decline. We can do it again. And I think if we focus on key populations, so foreign-born, again, this is the population you're going to be seeing. These are data looking at foreign-born individuals specifically and how we can get to elimination. If you look at this bottommost pink line, that is if we increase our testing and treatment of foreign-born individuals by 10 times more than we're doing today, we will get to pre-elimination early by 2030. It'll still take us a while to get to elimination, but we're really just looking at pre-elimination. So we need to increase our screening and testing of foreign-born individuals, which is what you guys do, and treatment of them so that we can get to elimination in California. The other very exciting thing is recently the U.S. Preventive Task Force, who is in charge of determining what preventive screening and diagnostic tools should be standard of care, came out with their recommendations for latent TB screening. They, after much deliberation, decided that adults who had increased risk for TB, which this first bullet, again, is applicable to our population here today, persons born or former residents of countries with increased TB prevalence, should be screened for TB infection with no cost sharing, so they will not have to pay for it. This is huge because a lot of people have to have a lot of co-pays and they can't afford screening or testing. So the U.S. Preventive Task Force has recommended that it should be done in this age group, so they will not be having any co-pays or cost sharing for their screening. Our opportunities for prevention, like I said, most TB cases in the U.S., because they are due to reactivation, are preventable. TB disease, as I said, has a lot of morbidity and mortality. Age and years in the U.S. are not reasons to consider not treating somebody or testing them. IGRAs and TSTs can be used to support your diagnosis, but does not rule out active TB disease. And as I mentioned, the IGRAs have advantages over the TST. Short course regimens have higher completion and less hepatotoxicity. We would prefer 3-HP, the short course, or rifampin, but we definitely do not prefer the INH unless there's other reasons to be using it. And TB elimination, although it seems really daunting, is achievable if we use some of our new tools with the IGRAs and the short course regimens. So that's it. There's my email if you would like to get a hold of me. And there are a bunch of references. Yeah. Sure. So the question is, what is the dosage of the INH rifampin dosing? For adults, there is a weight-based calculation, but generally for adults, it's INH 900 and rifampin 900. For children, it's a different dosing, which does, I will say, seem very scary because 900 milligrams of INH is very scary. But two things to keep in mind. One, we have given INH 900 twice a week as one of the old versions of LTBI treatment, so we've been giving this before in the past. And two, all the studies show that the hepatotoxicity is still much lower. So it is a higher dose, but it's being tolerated very well.
You say that the government are considering pay for the test. Are they going to do it? Pay for the test, TB test?
So the question is paying for the TB test, and who's going to pay? I'm not sure I understand the question.
See, the applicant may not be able to pay for the test.
The applicant might not be able to pay for a test.
Government go to subsidize the testing.
Can the government do subsidized testing? You're referring to the U.S. Preventive Task Force recommendation. Is that right?
Yeah.
I can't speak for the entire government, but with this, and I will say this is a draft recommendation, so the full recommendation should be coming out soon. But that is the idea with these recommendations from the Preventive Task Force, right? So like breast cancer screening, prostate screening, these are things that the Preventive Task Force recommends at certain ages because of increased risk, and they're not supposed to be. It's part of your standard of care.
The second question, you say that most of tuberculosis TB develop after 15 years they come to the U.S. So should the people applying for citizenship also get testing?
People who apply for citizenship, you mean the people who are coming over who are immigrating?
Yeah, usually they have applied for citizenship after 5 years. They have a green card, right?
You mean should they be rescreened after being here?
They should be rescreened, right?
As a requirement for citizenship, for changing your status. Yeah, so Mary is stood up, so I'm going to defer to Mary since she is eager to answer. I don't know if you're talking about as they enter because there is a requirement by panel physicians, but I'll let Mary answer.
Right, but you're talking about when they're naturalized. Is that what you're talking about, as opposed to when people? And I'm better at clarifying the question than having an answer. So
So at the time of naturalization, you do not have the requirement of a medical examination. So based on just immigration law, that would not be a consideration. Medically, at any time, I assume there is a need, right?
Right, so there are two aspects to that question. The first one is the legal requirements for naturalization, and yes, there is no requirement for medical exam or treatment, et cetera, right? But prior to becoming a citizen, they have to get that green card. So that's where you come in, and this is the step where we intervene, get the green card, get examined, get treatment for LTBI, and that's what we're hoping to promote. So do it in the first step as opposed to the second step. But yeah, by all means. Well, some will refuse, and we're hoping then that, you know, they will continue to be offered these chances with other providers.
When will the IGRAs become standard of care for the immigration physical? Because you would catch a lot more latent TBs if it was more affordable for people. But, you know, these people who are coming in for their physicals, they can't afford to pay for an IGRA.
Okay, if a patient had latent...
Oh, wait, hold on. Well, 1 second. Mary's going to answer the question. Sorry.
So the way I understand it is that, and you can correct me if this is wrong, I mean, I know that IGRAs are as low as $30 in California. What are they in the LA? In some areas, they are. So what are they in LA? What do they cost? So so if people have, you know, there's some ways to have an agreement so that the cost is less. And I know they've done that in some parts of California. But so what are you paying $200 per IGRA? That's charges $300. Okay. So because overseas it varies greatly, and it depends on who is, I think it's the distributor. It's not the company. And so, you know, that's...
So I would tell you
that you're going to catch a lot. You're not going to catch a lot more. You do a TST.
You're just going to convince more people to take treatment.
Yeah. You might convince more people to get treatment, but you're not going to diagnose more.
Because their TST should be positive too.
Yeah. Yeah.
I would say that when I was in Chicago, our QFTs when we started were in the $60 range, but we had lots of discussions and we dropped them to, I think it was $25 when I left. So there are ways, and it really wasn't that cumbersome. It was actually just required conversation. It is possible to get your price of your IGRAs dropped.
Right. So that's actually one aspect of the Partnership for TB Elimination that Dr. Sang-Yak Shin is working on. So if you have any questions about that, you should talk to him during the lunch break.
My question is this. So if the patient had latent TB years ago and treated with INH, and comes back for immigration physical exam, is completely asymptomatic, chest X-ray is required or not?
Is chest X-ray required? So, again, I'm going to defer to Mary because that's one in her area.
So on that particular person, what did you do as far as skin testing or IGRA?
So the patient had TB test positive in the past, so I'm not going to repeat it because it's reported positive.
What's the requirement? What's the requirement?
Is it documented?
Chest X-ray. So, but the patient was treated with INH.
But what's the requirement? I mean, do you have a document that says what the TST was in the past?
No.
Okay.
So
okay, and you know, we're not good at addressing this in these particular technical instructions. I mean, you can, you know, you can ask the person. Use your clinical judgment is what I would say. So if you go ahead and you do the chest X-ray, right now the answer is that you still classify them as latent TB.
Okay, thank you.
I wouldn't necessarily retreat them.
What is the cutoff age for doing a TST for the children? 2 years, 6 months?
That's Mary again.
The TST needs to be done for everyone 2 years and older. And if you suspect that there's TB in a child less than 2 years old, you also do the TST or IGRA. But again, in children, it's recommended if they're less than 5 that you do a TST instead of an IGRA. So even if they're BCG vaccinated, yes, you go ahead and you do the test. It's required.
And the only reason the IGRA isn't recommended for children is because there's not a lot of data on it. You can do them, but your interpretation is going to be a little squishy.
We do the TB test at 1 year of age to every child who is 1 year old in pediatrics. So probably that will be the answer to the question of when to do the TB test on kids.
I'm sorry, you do it in 1 year old?
1 year old.
For
Yeah.
everybody, even if they're not foreign-born?
No, no. I'm talking about regular American citizen born here. We do the.
Do you do a TST on U.S.-born individuals at 1 year?
No. In kids here, born here, at 1 year of age, is a requirement to do the TB test. No. We do the TB test, the lead test.
A requirement by whom?
No, but the CDPH. CDPH, not the immigration, but the CDPH.
For school, yes. So school requirements are very different and need a lot of work. There is this kind of, and they're all individual, locally based is part of the problem. So yes, you're right. Right now for schools, some schools, especially with kids, not in college age, but younger kids, are being required to get a TB. It should be an assessment first and then testing. Not everybody needs testing. It should be a TB risk assessment first, and if they need a risk assessment, and if they have a risk, then testing.
And so,
but I would say, again, some institutions would say, one school could say, no, I want them all actually tested, and that's not what we would recommend, but that people have said that. Sorry, yes.
And the technical instructions say 2 years and older. Mm-hmm. So when you're doing this exam, that's what you're doing, unless there's a reason to do it. You know, if the child has signs or symptoms, if they're a contact. So there has to be a specific reason.
The American College of Pediatrics would say that the TST is accurate from 3 months on. So if you need to do it because someone's in contact, it should be fine.
I'd like to add a comment to that about schools. In LA County, our requirement is a risk assessment. If they're foreign-born or they have other risks, then it is testing. However, you know, we've met with LAUSD, which is our largest school district in LA County, obviously, and they're on board with that. However, you know, individual schools may still be operating under the old guidance, which was test everybody. And I've personally had that experience with my kids were required to be tested even though they were born in the U.S. And I was like, no, it's been changed. And actually, I'm the acting TB controller, you know. So definitely we still need to educate a lot of the providers out there about this.
Question here. Mm-hmm.
How many percentage tuberculosis drug resistant in this country?
What is the percentage of drug resistance in this country? So multi-drug resistant TB hovers around 1 to 2% of all the cases in the U.S. And again, California, because we are so great, reports the most number of drug resistant cases in the U.S. So for us, that's about 30 cases a year. The resistance to INH is about 10% of all cases in the U.S. So, and that, if you look at different countries, will vary. I don't know who has a microphone over there.
We had a lot of good information. There's about 100 people sitting, and all we talk, what we have to do. I have one question. Can somebody tell whom not to do a CT skin test? No. When skin test is contraindicated. We heard somebody does it when it's 1 year for medical purposes, but we are civil surgeons. When not to do a skin test? Please answer.
When not to do. Oh.
What you need to do is you need to look in the technical instructions, and the time that you would not do a skin test is what we talked about this morning. So if you have someone who has documentation of a TST that was 5 millimeters or greater, it's signed by a healthcare provider, look at the requirements that are in the update or in the technical instructions, and then you don't need to do a repeat skin test. Or if they tell you that they have had blistering in the past, you don't need to do a repeat skin test. You go straight to the chest x-ray. But those are the only instances in which you would not do a skin test. 2 years and older. Right, exactly. Right. Well, you have the option of doing the skin test or the IGRA. If you're doing the IGRA, then if their most recent IGRA was positive and you have written documentation signed by a healthcare provider, you don't need to repeat that IGRA. You go directly to the chest x-ray. So I'm not telling you to always do a TST instead of an IGRA. I'm telling you there are very few circumstances in which you don't do either a TST or an IGRA as your first test. So that may be something to talk to Dr. Shin about, is what we were just saying. That he may be able to help.
So this is relevant to TB. For latent tuberculosis classification, say you have a patient who has documentation of an 8 millimeter induration on a TST, comes from Russia, for example, has a clear chest x-ray, but you have no documentation, for example, of an HIV status, so you don't really know, do they fall under the 5 millimeter cutoff or the 10 millimeter cutoff? Would you have to explore further, or do you assume that they're HIV negative, or what would you do?
For the for the I-693?
Sorry.
No, it's great. I don't have to do anything. I just stand here.
So you can only go by the information that you have. So I would just go by all the criteria for 5 millimeters. If they don't meet those, then you wouldn't mark them as being a category for latent TB. No, you would just look at all of the, you'd look at the different ones. Yeah. You'd talk to them about, what medications they take. So are they immunosuppressed any other way? Are they on a...
There are ways to kind of get at whether somebody is has a high risk factor for HIV, or as Mary's mentioning, what medications are they taking? Oh, well, I'm taking, AZT, and you're like, well, okay, don't tell me your status, it's fine. I'm sorry?
If it's not known or suspected, you wouldn't have to check.
Well, so for the 693 form, no. I would suggest that as a physician, you should, in general, offer HIV. Well, HIV is an opt-out, so you should test for HIV if you can't. It's not required for 693, I'll make that clear, but you should, as a physician, test for HIV. You should test for diabetes. You should do those sorts of screening exams for your patient's care anyway, and then you'll have that answer. But there are other ways around it. If your patient doesn't want to take it, or you're trying to really determine whether they fall into these other categories, you can ask other questions, like Mary said, what are the medications you're taking? How sexually active are you? Do you use condoms? No, I have 30 partners. I don't use condoms. Well, so there are other ways to kind of get around it.
Okay, thank you.
Okay, if we have no more questions, we can go ahead and break for lunch, which will be right outside.
Thank you.